Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thank you for joining us for today's webinar to help you navigate the operational aspects of review choice demonstration. My name is Molly Casey. I'm the Vice President of Marketing for Axxess. Before we get started, let me tell you just a little bit about Axxess. We are a leading home health care technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from Arlene Maxim, Clinical Consultant for Axxess, and Maurice Moss, Product Manager for Axxess. Arlene has many years of experience in the operational and clinical aspects of home health organizations, while Maurice brings more than 2 decades of experience in agency operations, specifically in the areas of reimbursement. We are delighted you both are joining us today. Arlene, we'll kick it off with you.
Okay. Thank you, Molly. It's good to be with you today. We're going to talk a little bit about RCD, Review Choice Demonstration. And our first slide here talks to the demonstration and why it's actually going on. So according to Medicare, they want to make sure that the payments for home health services are appropriate, whether it be pre-claim review or post-payment review. And the 3 things they identify are areas to prevent and identify potential fraud, waste, and abuse, protect the Medicare Trust Fund from improper payments, and also to reduce the number of Medicare appeals. The primary reason they started this, and if you think about it, it's to determine eligibility for the patient. So when we went through this whole process with PCR with the state of Illinois a couple years ago, CMS found that a number of patients that were being admitted were not eligible. And it was based on the information they were getting from the agencies with PCR. So with this demonstration, as it's gotten into other states, Ohio, of course, started a while back, and then we have Texas, Florida, and North Carolina coming up. They're going to be looking very closely as to whether or not the patients are actually eligible at the onset of their care. So if you can keep that in mind, these other things are true. They're trying to avoid fraud, waste, and abuse. They're trying to protect the Medicare Trust Fund, and they're trying to reduce Medicare appeals. But the real reason they're doing the review choice demonstration is to make sure that all of the patients that we're admitting in home health care are actually eligible for home health care.
Thanks, Arlene. There's some important time points that we need to be mindful of related to the review choice demonstration. And we'll start off with Illinois. So they were the first to start the review choice demonstration on June the 1st of 2019. They've now begun their cycle 2, where they've gone through 6 months of the review choice demonstration. They had their selection period from December the 31st through January 13th of 2020, and began cycle 2 on February the 1st of 2020. That will go through July 31st of 2020. Ohio began cycle 1 on September the 30th of 2019. Texas has started its selection process on January the 15th of 2020, and it ended on February the 13th of 2020, and they're scheduled to start on March the 2nd of 2020. North Carolina and Florida will have a selection period that begins on March the 20th of 2020, and it will go through April the 19th of 2020, with a scheduled start date of May the 4th of 2020. One of the things that we also need to be mindful of is, regardless as to how you're sending your pre-claim review submission or your ADRs for the post-payment, you will have to make your selection for the review choice demonstration via e-services. So if the agency does not currently have e-services and e-services login, they'll need to go to the online provider services link given by Palmetto to access e-services. And when you do that, you'll need to have your email address, your physical address, and a contact name and number to sign up for that service. You'll also need your provider number, your MPI number, and your tax ID. So to do a quick overview of the review choice demonstration, we'll start with the pre-claim review demonstration, which began in 2016. And it initially included Illinois, Florida, Texas, Michigan, and Massachusetts. So that started with Illinois. CMS decided to halt the program in April of 2017 while only Illinois was still on it, so they could revamp the program and deal with some issues they may have had to overcome related to the review choice demonstration. When they brought it back, it became a review choice demonstration, and Illinois began again in 2019. But now we have 2 states that changed. Instead of Massachusetts and Michigan, we now have Ohio and North Carolina. So with review choice demonstration, we have Illinois, Texas, Ohio, North Carolina, and Florida. So with this review choice program, one thing to be mindful of is the original program was 3 years. The review choice demonstration is 5 years. So that will go through 2024. Instead of now the cycle for each period where an affirmation rate is determined, that will be 6 months. So every 6 months, your affirmation rate will be calculated if you chose pre-claim review. Your claim approval rate will be calculated if you chose post-payment review, and that will be the time at which you have to make another selection. Once you submit a selection via PCR, Palmetto has 10 business days to respond to your request and either affirm or non-affirm or partially affirm your request. If your request is non-affirmed or partially affirmed and you choose to resubmit, Palmetto has 20 business days to answer your resubmission. So with that, we'll go over just a brief overview of the choices that are available to you once you've made your initial choice and then your subsequent choice if you have a 90% affirmation rate after 6 months. So your first choice is pre-claim review, where you send 100% of your claims prior to, or you send 100% of your requests prior to the submission of your final claim in order to have that claim completely paid. And Palmetto will respond in the 10 business days for the initial response or the 20 business days for the resubmission. Choice 2 is the post-payment, where you submit your claim as you normally would, and you're ADR'd for 100% of your claims, and then they make a decision based on the information that you sent in with the ADR. Choice 3 is the minimal review with the 25% reduction. That means that you are not choosing 1 or 2, and you've decided that whenever you submit a claim to Medicare, a traditional Medicare claim, you've accepted a 25% reduction on that claim. If you fail to make a decision or make a selection during the selection period given for your particular state, you will be defaulted to the post-payment review. So if you go on to have a 90% affirmation rate, then that means that you are now eligible to either choose between the pre-claim review, which we mentioned earlier, or you can choose between a selective post-payment review, which takes a statistically valid random sample of your claims, or you can do a spot check where 5% of your claims for a 6-month period are reviewed. If you don't make a choice during that particular selection period, you will be defaulted to choice 4. So Arlene will go into some details on each one of these selections.
Thanks, Maurice. So as he said, you have some choices here, and that's why it's called the choice demonstration. So we want to make sure that you choose the correct choice for yourself. Pre-claim review, as far as I'm concerned, as a consultant, would be the only choice that I would think that people would want to have, although it seems like it may be some extra work, just actually a matter of getting things done at the front end that you may wish you had once you get like an ADR and something like that. So again, as I mentioned earlier, this all has to do, the review choice demonstration all has to do with patient eligibility. So with pre-claim review, what they tell us is that all the episodes of care are subject to pre-claim review. If you choose that one, just know that every patient you admit will have to go through pre-claim review. There's an unlimited of resubmissions that are allowed for a non-affirmed decision. So depending on how many mistakes you make or they make on their end, it doesn't really matter. It's not going to hurt you on your end. You can resubmit things with errors, trying to get the errors out. And by the end of it, and what I've found talking to providers in Illinois, they found that this was very helpful actually, so that they made sure that they got things right on the front end. More than one episode of care may be requested on one pre-claim review per beneficiary, and then the claims associated with provisionally affirmed requests will not undergo further medical review except in limited circumstances. So just because you're not on pre-claim review doesn't mean that you're never going to get an ADR on this particular claim. They're only looking at certain amounts of information on the front end, so that there's still a potential for you getting other reviews going on. And the second choice was post-payment review, and this again is, I don't understand why people would do this, but some may. 100% of claims will be reviewed after final claim submission. So this means that you're going to be on 100% of ADRs, and that's not something most people wish to be on. However, those that did not make their choice, particularly in Texas, I heard that there were about 7,000 agencies that actually made the choice. So we know there are a number of agencies in Texas who did not make a choice, and that is going to cause them to go into this 100% of post-payment review. So this was updated on the 6th of this year, on January 6th of this year, and it's a default selection if no review choice is made. Once the claim is submitted, Palmetto is going to process the claim and then ask for an additional documentation request, so that you will have to submit your medical records as you have in the past with just routine ADRs. If a response to the ADR is not received, an overpayment notification will be issued. After a 6-month period, the claim approval rate will be calculated and communicated to the agency. And that'll cause even more significant problems, because you will likely have a higher denial rate based on that post-payment review. Minimum review, some agencies have selected this. It's another choice that I would question as to why someone would want to do this. But 25% of the payment reduction is a 25% payment reduction. The agencies that remain with this option for the duration of the demonstration. So this will be a 5-year process for you. All claims have a 25% payment reduction. Providers who make the selection will be excluded from the regular MAC targeted probe and educate reviews, but you are subject to RAC reviews. And I did hear recently that RAC reviews are on the upswing with home health. We've been left alone for a number of years, but RACs are starting to occur. So providers that select this option will remain in this option for the 5-year demonstration period as well. Some things that I recommend for agencies, and just some opinions that I have. Non-affirmation, just know this, that non-affirmation is not a denial. So some folks want to know if they can appeal the non-affirmation, and that's not the way this is handled. And non-affirmation would not be a denial, so there really aren't any appeal rights with this. Make sure that you're tracking your RCD responses, and make sure that you have dates, times, and the folks that you spoke with or that you communicated with when you have responses with your claims. Make sure you have you understand what the face-to-face issues are. I've heard from a number of people in the Ohio and the Illinois demonstration that they are having some issues with face-to-face. So make sure that you really understand what face-to-face items you need to have documented on your face-to-face documentation, and that the homebound status is clearly documented so that the reviewer does not have questions on whether or not the patient's homebound. I would highly recommend that you train your referral sources, make sure that they understand that you need this information quickly, particularly your physician's orders and your face-to-face information. You're going to need that to be able to follow up and actually submit this to Palmetto. Our next slide talks about operational best practices and just some things that I want to just highlight for you. So there's 5 tasks related to the pre-claim review. The first task has to do with your face-to-face, as I just mentioned. So if you make sure that you have the correct physician on your face-to-face, if you don't have the certifying physician on your face-to-face document, for instance, if you have nurse practitioners or physician's assistants completing your face-to-face documentation, make sure there's a statement where they indicate that they've collaborated with the certifying physician. So any kind of statements you might be able to procure. So for instance, if you have a coordination of services document, that indicates that the nurse practitioner, non-physician practitioner actually talked to the certifying physician will be very, very important. You want to make sure that you don't miss that. Your face-to-face encounter notes too can include discharge notes from the hospital, or they might be a physician-related note on a visit that the patient had in the physician's office. And again, that face-to-face encounter can happen 90 days prior to the admission to home care or 30 days afterwards. So just be sure that you have something that is clinically sound, that the information on the face-to-face document is clearly related to the reason that you're admitting this patient to your agency. Agency-generated records, anything that you have that'll support both the face-to-face encounter and support the reason the patient is eligible for care by your agency will be important. OASIS documentation, and not just that the OASIS items are checked in the checkbox, but make sure you have sufficient narrative documentation to support every check you have in every checkbox, so that when the reviewers look at your documentation, they can clearly see that the patient is eligible for home health care. Your therapy evaluations will be important. If you happen to have a social work evaluation that comes in before you actually submit your pre-claim review, that would be helpful as well, if that helps support the reason you are admitting this patient. Your physician's orders and any kind of coordination notes that you have that, again, will support the reason that you are going to be seeing a patient and give the reviewer a reason to affirm your claim. The plan of care needs to be signed and dated by the certifying physician. Now, this has nothing to do with the person necessarily that makes the face-to-face assessment. So your certifying physician that signs on that plan of care needs to have it signed and dated. You cannot date the form for the certifying physician. Make sure that the physician's his or her signature is legible. If it is not legible, I would recommend that you have a sign-in sheet where the physician actually printed his or her name and then actually put their signature next to it so that you could include that with your pre-claim review. The signed and dated physician's certification is similar, very similar to the plan of care. It's just the certification at the bottom of that plan of care. And then make sure that you have the criteria number 1 and number 2 related to homebound status. We won't have time to get into that. That's probably a session all by itself, but make sure you look up if you have problems with that. If you contact us, we'll make sure that you get a copy of this, but there's criteria number 1 and number 2, making sure that you identify what type of equipment they have, what type of that they need to use to go outside the home, what kind of medical diagnosis that might preclude them from leaving the home alone, those types of things. So the homebound status definition changed a few years ago. It became a little more clear as the types of patients we should be seeing, and that needs to be also included in that information. So RCD reinforces the efficiency and urgency needed to be successful in PDGM also, as well as RCD. So a timing, again, with a new 30-day billing period. You need to make sure that you get your physician's or signatures as soon as possible. I've been reading quite a bit online and in some articles about PDGM indicating that that's one of the biggest hurdles agencies seem to be having, is getting doctors to sign in a timely fashion. So you want to make sure that you have follow-up windows with physicians to make sure that they are getting them signed in a more timely manner. Your documentation as far as face-to-face in 90 days is going to be a key. Of course, they allow up to 30 days to get that, but sometimes that's a little tricky. If you have to wait for 30 days and not knowing whether the patient's going to have transportation, not knowing whether they're going to be willing to go to the doctor is a little tricky. So one of the things that I've always recommended to agencies too is to make sure they have a visiting physician service. If you have that available in your community and you have a patient who's having difficulty getting out, that's another standby for you for getting that face-to-face done. So your intake staff, I've been talking to folks over the past year about how important it is for the intake staff to make sure that they get as much information. The intake staff should be like one of the most critical portions of your corporate operation now. So they need to make sure that they understand what information they need to get and to assure that the clinician, whether it be the therapist or the nurse, when they go out to do the start of care, they have as much information as they need to get that start of care going. So again, the referral information as to whether or not the requirement might be met in progress notes, discharge summaries. So the intake staff would be your first line of defense to make sure that the face-to-face documentation that would carry over into the patient's start of care is adequate for sending in as part of RCD. Accuracy, again, intake, here we see this again, intake should take extra measures to ensure the diagnosis listed on the face-to-face reflects the admitting home health diagnosis. These don't have to be the same numbers or exactly the same, because we have some nuances in home health coding that's different than the physicians, but the diagnosis has to be closely related, and you should be able to show in your documentation how that relationship has occurred. So if a follow-up physician is needed later, PCR submission and billing is going to be delayed. So you want to make sure that you get as much of that up front. The speed of getting information with not just RCD, but with also PCR is incredibly important now. So the appropriateness of the primary diagnosis, specific enough to be placed in the PDGM clinical groups. Again, getting information to the physician, and I believe Axxess has developed a document that you can use to take to your physicians and your referral sources that will help them identify diagnoses that might be helpful for the physician to know about, or the referral source, and that will be helpful to you in getting things turned around more quickly.
Thanks, Arlene. Thank you. So in addition to the things that Arlene has said, there are some additional guidance from Palmetto regarding the new PDGM requirements and what, if any, changes will be needed related to a PCR request. So the question that is posed here is, what happens if a change in focus is completed in the first 30-day billing period? So we know now with PDGM, patients may have one issue going on in the first billing period, and then a change in focus to another primary diagnosis could happen in the second 30-day billing period. And so the question specifically says, if I only submit a PCR primary pre-claim review request for the first 30-day billing period, then later submit a PCR for the second 30-day billing period, and the diagnosis changes from the first to the second billing periods, will the documentation provided with the first 30-day billing period suffice? And Palmetto's answer to that is yes. And the reason for that is because the episode of care is still 60 days, and the certification or recertification is viable for that length of time. And then if a provider submits a PCR and the diagnosis changes midway through the episode, a new plan of care or recertification would not be expected, until the new 60-day episode. So we don't change anything, and all of the documentation related to review choice demonstration clearly states that there are no changes to the current paperwork requirements that we have. And then finally, the same plan of care, as long as the dates of service covers 60 days, used for the first 30-day billing period would be used here as well. So we know that we have that upcoming change related to the change in focus that might cause a different primary diagnosis from one 30-day billing period to the next. That will not require anything different from a PCR review choice standpoint. One final thing to be mindful of is care plan oversight. Physicians can bill for certification and recertification of patient eligibility for Medicare-covered home health services, and under a home health plan of care, including contacts with the home health agency and review of reports of a patient's status required by physicians to affirm the initial implementation of the plan of care that meets the patient's needs per the certification period. So when you're dealing with physicians, you can also make sure that they're aware that that review that they do of that plan of care is a billable service, and there are HCPCS codes that they can bill under related to the initial certification and the recertification when they're doing care plan oversight. And finally, we have some resources listed here. These specifically address some of the things that Arlene and I mentioned related to homebound status with the MLN Matters, FN SE 1436, some of the review choice demonstration FAQs, and some of the initial experiences that were happening in the Illinois agencies, and some lessons learned from them are here from the Illinois Home Care and Hospice Council. We also have a review choice demonstration flow chart and some checklists for the early billing period and the later billing period. And we are available for any questions if anyone ever needs to contact us related to review choice demonstration.
Great. Thank you, Arlene and Maurice, for sharing your wisdom and your expertise on navigating review choice demonstration. And thank all of you for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Thanks so much. Have a great afternoon.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.